for more specific and more detailed principles that would assist with mitigating these key issues that we highlighted in our research, such as how is data stored, managed, and processed. Thank you.
In line with that as well, do you think that the current regulatory processes, especially with, again, the enactment of the Digital Health Act, which is a big thing, especially
as well as more discussion around AI when implementing the Digital Health Bill? Yes.
Thank you so much for that. Just to throw it back to Martha just a bit, since we're still on the topic of regulations and we've looked at it from the research that has been conducted by both Joshua and Natasha, which brings in certain emerging technologies in there. Just to throw it back to you, Martha, do you think that the current legislative process in terms of especially the health sector, in as much as it's generalized right now, and of course we get the foundations from it from the Constitution, then it trickles down to other subsidiary legislations, do you think that there's a strong need for specific health sector specific laws that relate directly to digital health or e-health? I know there's the e-health bill that's coming up, but how specific do you think that the terms and conditions within these specific regulations need to be able to canvass the challenges and the gaps that are still lingering and existing?
I think we have very many laws. When it comes to digital health, the Act is a step into the right direction. However, we need more regulations to explain the specific aspects of the Act. For example, what does the agency do in the Data Protection Act? Regulations when it comes to e-waste management, regulations when it comes to the comprehensive integrated health information system as provided for in the Act. So I don't think we should have specific laws like an act. However, I feel like there's need for more explanation when it comes to the various important aspects or various important chapters in the act. So more regulation, and the regulations should be specific to the specific digital health needs. For example, if it's in a county setup, we have different health needs. If it's in the context of probably youth or women or key populations, we need to ensure that the salient issues that they are facing when it comes to accessing digital health technologies and services are addressed within regulation, because coming up with different acts can bring a lot of confusion. We know that there was a Senate e-health bill that was being discussed the other day around the same time that we were talking about the Digital Health Act. So if we have different laws and policies speaking on the same thing, there's a lot of confusion. So we need just a little bit more regulations or rather to be developed, and also we need the different lawmaking agencies to work together so that there's less confusion when it comes to coming up with comprehensive and user-friendly and people-friendly laws and policies.
Thank you for that, Martha. Now we look at the perspectives of developers and entrepreneurs. So, Walter, to you, would you mind please sharing with us your personal experience and any challenges that you've faced in terms of operating digital health platforms in Kenya, especially as it relates to sort of implementing the already existing laws and policies within your development and in entrepreneurial processes?
First of all, what I can say is that regulations are good in terms of curbing information and also trying to protect citizens. The problem and challenges that we are having is that the regulations are a little bit complex and they don't have clarity on what laws and regulations apply to what products. We have so many acts in the process, and the acts are a little bit confusing when it comes to regulation, because if you have several products that or an innovation that has different products and services, it will require you to go through so many bodies for you to be able to get which law and regulation apply to a certain kind of product. These ones takes a lot of time more so when you are bringing up a product to the market, definitely, because before you move from one institution to another, definitely it might take you like a whole lot of period, can take you up to a year or two. Yeah, because sometimes as we go by, because the digital health space is really accelerating in terms of development and growth, so before you comply, you'll find that there are more acts and there are more changes that have taken place, and from the innovative perspective, it means you have to go back, try to iterate and figure out how to enable some of these innovations to fit into the current regulations. Of course, the other challenge that we have had in the space is building trust with the healthcare providers and the users who are the patients. Since technology is a little bit, unlike these other areas of e-commerce and these other spaces, the digital health space has just begun. So a lot of people are still hesitant on using this digital health product because they're unsure and don't really understand so much about how they work, how is their data protected, what security measures have been put in place, and how they are going to operate. This one also goes to most healthcare providers. Some of them usually fear certain information from the hospitals or from the clinical part going to, as you can see, the digital, the Data Protection Act gave out this data subject to be the owner of the information. So a lot of providers still are not free giving out this information because of fear of legal actions in case of misdiagnosis and other information that can take place. So they fear that if the users or who are the patients are going to have this data in their hands, definitely, and there's something along the way during the treatment process, they can either take legal action, which can jeopardize their work. These are some of the main challenges that we have gotten while in operation in this space. Of course, there are a few strategies here and there, definitely, which we have tried to put in place for us to be able to navigate through. But still, there's a lot of challenges because the space is evolving, and each day we have different things that are taking place. The first one, which I think also can be very beneficial to other innovators or other people who want to come to this space and to the innovation space. I believe that we need to update ourselves now and again to be able to be compliant with the current regulations, which are changing very fast. There are also other places, other things like the AI that are yet to be regulated, which means there's still more discussions and collaborations which need to take place between the private sector and the government to be able to come with, understand the insights which takes place from the innovation perspective and how they can be able to be regulated so that they are effective and safe to human consumption. The second one, of course, is to seek legal entities to be able to assess the innovation. This one is to ensure that your innovation aligns with the current regulations and laws that are existing. We have, you can either look for a lawyer to interpret the regulation process and what is required for an innovation to be able to take place and assess the risks that might be involved during your innovation process to enable you comply with what is required and how you can be able to move to the right direction. I also believe that having some good engagement with the regulators can give you a leeway to navigate through the complex and fragmented area. You can discuss with the regulators and be able to discuss with them about the innovation and what you're doing generally, so that you share a few things here and there about the regulation process and what you're supposed to do to enable you be able to move ahead in an easy way. Lastly, on the strategies, if you're in an innovation space, definitely you should have a compliance plan. A compliance plan is a document that outlines the measures that you should take place in case of breaches, and the steps that you are following to be able to be compliant with the current existing laws. It's a document that should be updated here and there based on what is happening, the new regulations that are coming in place, and be able to fit into what you are doing so that you can remain compliant and safe within the healthcare space.
Thank you so much, Walter, for those insights. There's something you've mentioned about building public trust, and that emanates from the fact that a lot of these technologies that we're using, it's always the end user who either benefits or doesn't benefit from them, especially with digital health and in trying to establish the fact that everyone attains the greatest standard of healthcare. So as a parting shot from all the panelists, just a brief question. What do you think would be the best way to build public trust, especially with the kinds of laws that are now coming up and with the kind of technologies that are now being used? We'll start from Martha and then come back.
Thank you, Florence. I think the best way to build public trust is engaging the public. I know in this law development processes, the Ministry of Health has tried to engage the public, or at least advocates of the public, which some of us as Kerlin or Transform Coalition and our partners consider ourselves as. But there's more need for engagement of communities. We need adequate time for public participation. We saw how fast the Digital Health Act was passed. I think we had a few days to give in our comments. So we need more public participation so that we can encourage public confidence in this space, and also to ensure that there's a lot of sensitization. Now that we have the current laws, we can focus more on sensitization so that we ensure everyone understands what these laws and policies are about, what these technologies are about, what these services are about, so that we can build more confidence in people seeking digital health services as an alternative to actual physical healthcare service access in hospitals and other healthcare establishments. So I think that would be my parting shot. Let's engage the public more, let's talk to them more, let's sensitize everyone more, not just the professionals or the professional stakeholders within the space. Thank you.
Okay, with building public trust, I believe that trust is usually gained, and this one can be built through trainings and teaching more people on what is happening around this space. A lot of people are still not so sure. They don't know people at Mashinani from these other areas. They still don't know very much about digital health. So either the government, the private sector, and different stakeholders need to come together so that they can be able to train different users from the different spaces. Either can be through the healthcare providers, can be through the users, so that they really know and understand what is happening around the digital health space and how they can be able to benefit from these upcoming innovation.
I think from my ends, I would say the burden of proof lays with the developers and owners of these platforms. So more of a privacy by design, where the burden is not on the consumer to see whether their rights are being safeguarded, rather it should be on the developer, so they're ensuring that the products are in compliance with our laws?
I think for me, I'll say it's important to, first of all, educate the public on personal data, also to be transparent with them about the personal data, especially for data controllers who are in charge of these platforms, to be transparent, and also provide more detailed information about the personal data that is collected, how it's processed, and everything, so that they can gain trust in people that they assign their personal data to. Yeah.
Thank you all so much for your brief and comprehensive insights on digital health landscape in Kenya. I'm seeing there's a couple of questions. Do we have time to answer them?
Yes, we'll take how many minutes? 3? 5. Okay, we have 5 minutes to respond to the question. Before we go to the online, first 3 hands up would get the first opportunity to answer on air. Okay, so on air 1, 2, 3. I'll make an exception for Dr. I know you have a comment. Yes. So please keep sending your question through menti.com. Send all your questions, yeah? So don't be left out. So we start with Onea. The first of his name.
Okay, thank you panelists for that good session. Mine is a brief one. We are moving so fast with digital health and digital health technologies in terms of healthcare and all the other aspects. My concern is we've all been talking about security, data privacy. What are some of the best ways that as key populations we are going to feel safe even as we enter into this fast-moving era? And when I talk about this, we have had a struggle even to implement some of the best practices in terms of, let me say, we are moving into IBBS in the next few months, and there was an issue about using biometrics, identification, and just being able to ensure that our data is safe. So what are some of the best solutions that you're coming up that as key population, as we also think about this, about privacy, security, will be able to adopt? Thank you.
Thank you very much. Legal minds in the house will tell you the law is never clear.
Thank you. My name is Philip. I have a question to Walter regarding the strategies that you use to make sure that you're compliant, and it's more on knowledge management. What are your thoughts on communities of practice as a platform for creating that awareness to other innovators? Because we know at times if everyone has to go through a lawyer to get that legal interpretation, some of them may never afford that. Thank you.
Thank you very much.
Thank you. My name is Peter Witty. My question is, Kenya is a signatory to the Global Health Treaty, and we saw what happened in COVID, where the platform for managing COVID was all at the control of Johns Hopkins University. So how are we going to make sure that our data is protected, considering the happenings that are happening globally? Thank you.
Thank you, Dr.
Thank you. I didn't understand this question of Johns Hopkins, because COVID data for Kenya is being handled by the Kenyan government. Maybe I will need some clarification about that. But my comment, mine is basically a comment, because there is the generalizability on health data. And I see individuals getting worried that this data may land in the wrong hands, be used for the wrong purposes. But I would like to state from the onset that one, the present system where it is paper-based is worse than the digital system. Because if you walk to any hospital, you can steal that file, and it happens every other day. The file can be rained on, it can be destroyed by any other thing, including rodents, and so many other things. So I want to create comfort that first, the digitization of the health data is superior to the present system. Number two, individual data, once in the system, may not be very useful to whoever wants to steal. Unless, of course, you are a very important person, maybe you are in those senior levels, and I don't know how many of us are in that level, that somebody will be interested in your data. But group data becomes important. That's why we talk about the big data era. So when governments, like the Kenya government has put in place measures to ensure that that data is secured, including even by law, it is not an easy task, because even the senior people are worried that their data may land up in the wrong hands. And this is the problem that we face every other day, that we get our data taken by other people, I'll not name here, and then they profile us. And that data is available to them because it is paper-based. We use their systems, we use the papers which they can walk in, they say we are doing research, but they use that data to profile us. So I wanted to just to give comfort that moving towards digitization is superior to the paper-based systems.
Thank you very much. You have 3 minutes to respond to the questions, then we'll take these ones in another 2 minutes, then we'll be done.
Also to add on what Dr. said, during the process of data protection, definitely from the system perspective, we are trying to do what we call anonymous data, whereby we detach the user from the data, just in case the information is able to leak out there, they cannot be able to know specifically that this data is from so and so within a certain place. We also try to do what we call end-to-end encryption, whereby the information is encrypted while on transit from either your phone to the hospital, and whoever who might get access to the data along the way cannot be able to understand what the information it's holding within the setup of exchange within the information exchange system. To answer on Philip, the story about affording the legal entities, of course we have lawyers here. The best practice and the best way which I feel like maybe we can be able to use is to collaborate and also be able to the lawyers are not so bad actually if you discuss with them and be able to get how you can be able to work together in terms of the different ways you can compensate. Definitely if they come on board on your system or on your organization, they do understand, because they are also human, just like you. As you are fighting to work hard and be able to bring things on the table, they are lawyers. You can sit down and have an MOU discussion on, based on what they can get for compensation in terms of either shareholding, within your organization, and other means that each party can feel comfortable to go with.
Have we responded to all the questions? You have. Okay. One comment from Sylvia, then we take the online one.
Yeah, so I wanted to add on to the comment on the communities of practice, and this is an approach that we have considered as an organization, KEHIA, because I think a couple of months ago, I think in July, we had a convergence workshop, and that's basically just bringing all stakeholders and players in the digital health environment together. And we had people from the ministry, people from private sector, development partners, and everyone's role in the workshop was to kind of think through how they can contribute to expanding the vision and executing it. And one of the propositions from the workshop was that we should develop a community of practice that we would host, just to make sure that the knowledge that is shared within the field continues to grow, and we have a point of contact that anyone who needs any information on anything that is about digital health can come to the community and consult community members, and it's going to be voluntary. So anyone who is a part of the community can share knowledge, and anyone can reach out to anyone who's part of the community and there's multiple tracks, so you can go to anyone depending on your interest, whether your interest is a governance angle or an AI angle or part of one of the the slide we showed yesterday. If your interest is in one of the boxes that was showed there, you can go to someone who is specialized in that field and you can consult. So it is a model that we are exploring, and we're hoping that in the next couple of months we should see some traction in how it expands. Yes, thanks.
All right, so we have 6 questions. So what are some of the outline penalties? By the way, is it clear in the law? That's the first question. What can you all say about digital registration of newborn using microchips? Do we have regulations in place? I remember this question also came up yesterday. Let's decolonize our reporting by documenting the positive narratives about the digital health tools and work. Does the law have a clear outline of the privacy policy and what should be contained? Okay. Because some of it is as PR. Okay. The innovators and developers ready and aware of the digital superhighway? Are their platforms ready to plug in? I think that's a good one. You can talk about data privacy, encryption, safety, privacy, yeah. And at Kitili, the father of AI, Geoffrey Hilton, retired from New Innovation with a question that AI is moving from memorization to deductive reasoning. What if they take over as in ChatGPT? Are we prepared? Panelists, the last one. What is your take when it comes to health research and development in this space of digital health? So please take 2 minutes. You can decide amongst yourself who is going to respond to which questions.
I think we start from Joshua since his question seems most interesting.
Let me start first with if the law has a clear outline on the privacy policy and what should be contained. So the Data Protection Act itself doesn't have a clear outline on the privacy policy, but the Data Protection General Regulations have a provision on policies, and this can touch on privacy policies. So yeah, it's you can find something to do with policies on the Data Protection General Regulations. And you're asking some do it as a PR. No, I know some organizations may just copy and paste, but it's good to really analyze and draft a good privacy policy so that you are compliant with Data Protection Act. Because if any issue arises, the data controllers will be liable for any misuse of personal data. The other one on AI. I think I might ask Natasha to answer that, because she's more AI is a specialty.
I will try. Regarding AI, I think what the question is alluding to is the idea of training sets, the data sets that we use when we're feeding this sort of AI systems. In terms of deductive reasoning, I highly doubt, because ChatGPT is quite simplistic in nature and it deals with a different type of function in nature. So when it comes to health, I think they're quite more complex than it seems. So I don't think deductive reasoning is something to really worry about within that space. Thank you.
Maybe I'll try to answer. The innovators are developers ready and aware of the digital superhighway. The platforms ready to plug in? Yeah, of course, the current platforms that are being developed are ready, yeah. We are creating some exchange forms of API, exchange forms of information centers, whereby as we can be able to see with the universal health care, whereby there's going to be a body that is going to govern all the data, because this data has to go to the national government. So we are creating APIs and information exchange systems that will be sharing the information with the national government, so that this information is centralized and able to be accessed from any other place based on how the universal healthcare is going to move.
Okay, Florence, I don't know whether you have final remarks as we wind up on this panel.
My only
there was the last.
The one on what is your take when it comes to health research development in the space of digital health. From my end as a researcher, I would say that the space is wide, and depending on how you look at it, you can decide to separate them in terms of you're only doing research with respect to health, but it was with respect to health in what categories? Because it's quite vast and it's quite wide. You can decide to take the route of looking at it in terms of digital health technologies. In terms of digital health, in and of itself, digital health is wide and large. You can decide to look at it from the medicine or the medical perspective if you're a doctor. If you're looking at it again in terms of research and development, and you also keying in aspects of innovation, you're also keying in certain aspects that relate to policy and regulation, so you can intertwine all of those within one thing, to be very honest. But at the end of the day, it depends on what angle you're looking at it. For digital health, you can look at it also from a human rights perspective. If you're doing it in terms of research, you can look at it from as basic as policy. You can look at it in terms of innovation. You can look at it in terms of assistive, we call it, you can look at it in terms of what the principle of distributive justice, how people from urban marginalized areas are able to access digital health technologies as opposed to other communities. You can look at it in that angle. Like I said, it's quite vast and it's quite wide, and I think there's a lot of space for people to do a lot of research in that area, especially from Africa and from Kenya, because more often than not you find that we rely on research material that comes from the West, as opposed to us telling our story, which also feeds into the question, or I think it was more of a comment that talks about us changing the narrative and sort of looking at it from a decolonial perspective. So we need more of research from our own stories and what's happening from our own areas, as opposed to constantly relying on information that comes from the West that doesn't really speak to what's happening within our continent and our country. So that's what I'd say.
Thank you very much. Please let's put our hand together for them. As they exit this stage, that has been an intense panel with the legal minds. Thank you so much, Florence and your team. We really appreciate your insights on this important topic. So as they take their seats, Dr. wanted to just comment on the issue around research and development, R&D. So in 1 minute, please.
Yes, I just wanted to add on what he has said. I think we should also recognize that with data that is now coming and is digitized and is going to be virtual, and more importantly, it is longitudinal. So even before you are born, even before you are conceived, data is already available. And I want to explain this so that you can see the import. Once we track somebody's history throughout their lifespan, maybe before they were born, the mother missed the 4th antenatal clinic, missed a particular vaccine, it will be captured. The system will know that this person did not get that. At birth, the history around the birth is known. As you grow up, you are getting vaccines, it is captured. Until you die, or until you marry and then you die. The import of that is that when you combine these over generations, we'll now be able to understand individual, personal, makeup and the genetic makeup to an extent that, you know, the global world is now moving towards individualized care. The way you react to a particular medicine is not necessarily the same way another person will react to the same medicine. And this can only be found by this process of having big data. If you have an inherent genetic disease, it will be known that this disease can appear in your generations, maybe 2 generations or 3 down the lane. So we can link up and pair the children at some stage when you want to marry somebody, and you know this one has this particular disease or has possibility and the other one, then they can be advised that in view of your great-grandparents having this problem, you people risk having ABCD. Like you can see how the royalty in Europe and UK, for example, we know hemophilia has been running in their families. How do you get to know? Because it started somewhere long ago, and therefore it can be tracked, and people can now be given proper advice. So we should not be so averse towards our data being collected. In fact, it is more beneficial to us, as I said, at individual level. And we should not be saying that this data may leak. The government is putting in place all the measures, because the response from the government is not just Ministry of Health. Ministry of Interior is involved. And I want to give you a classical example of what happened in one of the referral facilities early this year. There was a ransomware. I will not name the facility. There's somebody who managed to crack the system in the hospital, and it became a ransomware. How they handled it, I don't know. But that system was alien. So, because the county had decided to buy the system, so getting back the data was a problem. How they managed to handle it in the long run, I don't want to know. And I don't even really know. But I'm trying to say that systems that are developed by the government and the involvement of the multi-agencies, particularly the Ministry of Interior, is not an easy thing. Recently we heard about the attempt towards e-citizen being cracked. But the government came in very handy to make sure that that thing was done away with very fast. So it's the same with the health data. So we should not be so worried that the government is so pervasive towards the concerns that Kenyans have about their health data. When you walked in here in some of the hotels that we go to every other day, you are asked to even produce your ID, your telephone number, your name, your ID number. We give them without even thinking through it. But when it comes to health, we start asking questions, and I don't understand why. I think this one is a place where you are getting the services. The other one, you don't even know how they are using that data. But I rest my case there. So over to you, moderator.
Thank you very much, Dr. Ri. Please let's give them another round of applause. So, ladies and gentlemen, that was the first panel, and we have managed to get very great insights from the discussions. One thing that gives me comfort is from what Dr. is saying, that the government is putting in place all the necessary security measures to make sure that our data is safe. Yeah. So right about now, request as we go to the second panel, and I said that it's a very cold morning, so we need to keep warm, and to do that we're going to conduct an exercise. Let's all be upstanding with our smartphones. We'll take a selfie and we post it on our social media pages. We need to make noise. We need to let the world know that we're here. Right? You take a selfie with your immediate neighbor. That's why, please make sure that you have one. So the hashtag, just listen to the instructions. Consent. You're posting it on your own social media platform. Do you need a consent for that? Thank you. So we are using the hashtag Digital Health Week 2030. We are using UHC 2030. And we're also using hashtag Digital Health. And these are some of the organizations to tag. Some of you will get an opportunity to use that. So you please tag Transform. Transform is with 4M _health at Transform Health KE. Tag Farm Access KE. Tag White Ribbon Alliance _KE. Tag at PHDA _Kenya. Tag at Love Africa. Tag at Health _X _Africa. Tag at Naya Kenya. Tag at CFA Global. Tag at Youth Alive Kenya. Tag at MOH, Ministry of Health. Tag at Kelin Kenya. Tag yourselves and all your friends and all your organizations. Is that okay? In 1 minute, as Patricia prepares to introduce her panelists. To put my face, we are here. Thank you. Thank you. Usiharibu picha, please smile. Rehema, you're taking a selfie. Patricia, thank you very much. Please tag all the organizations I've mentioned at Transform Health. Happy to see Dollarman. So we are very safe. We have Dollarman in the house. Karibu sana. Patricia, please let's take our seats as we welcome Patricia to introduce her panel. Patricia and your team, please come forward. A selfie? Sawa. You want to take a selfie? Please do. Please take a selfie. Or you want a photo? Oh, you're looking lovely. Patricia, you want to join them? You're looking lovely. Okay, thank you. Please, let's welcome Patricia. Let's put our hands together for her. Patricia, karibu sana. Thank you, DJ. Play it without chiki. Thank you. We are going to the next session, and this is a community panel. As I had mentioned, we adjusted the program because of one or two technicalities. So we have moved forward the session 9 to start now. Patricia, the floor is all yours. Thank you.
Is my mic on? Hello, yeah. Hamjambo. We are happy to be here this morning. From yesterday, we've been hearing a lot about digital health and the different presentations that have been made. But today, I think we are going to hear from recipients of care. because a lot of the digital information we were getting yesterday basically from the health facilities. And as recipients of care, I think you might want to hear our experiences as well. So this morning, I'm privileged to have in the house Anne Okaro, the chair of the Network of Teachers Living with HIV, Kenny Pote. In the house, I have Peter Udenyo, who is a board member of NEFAC, the National Empowerment Network of People Living with HIV. And with me is a young person, the very empowered Cindy Amaiza, the CEO of Y+. So from yesterday, there was a component that I heard Dr. Sitenei talking about yesterday, and I think this is the team that will be able to take it away today. He talked about that, was it last year, that there was a community that felt they were being profiled using the digital technology. So part of that community is one, Patricia Acero is standing here today, and a few of us are here. So we will get to understand what are those fears, what are those concerns that communities have in terms of digital technology, and what do we think about digital technology in terms of the health provision. So basically, I'll start with Cindy Amaiza. Cindy, as the representative of young people, basically we come from a community that is stigmatized a lot. And of late, we have also realized that we are also criminalized. Amamukona criminalization the other day. You saw? Yet somebody alispit kwa chakula. So instead of that being an issue, that that person did something gross, it was the HIV status that became an issue. So we come from that type of community. And what do we think, Cindy, representing young people living with HIV, how can technology, has the adoption of digital technologies improved health delivery and outcomes for the communities that you represent?
Okay. Thank you very much, Patricia. For me, I think there are always two sides to one coin, right? So definitely there have been improvements in terms of access to healthcare. We have seen that right now young people can access information from the palm of their hands. They can get accurate and factual information about their own healthcare from their laptops, from their phones. So it has been easier to access healthcare. However, as Patricia said, it also comes with its own downfalls. We have seen that there's also the profiling of people living with HIV, especially key populations. It has been very detrimental to know that your information is out there and you don't know who is accessing it. But we are also happy to hear that there are very many sort of improvements that the government wants to put in place to just ensure that we can access our health better, and that the security and privacy of our information is always guaranteed. That's a positive step. But we are also seeing, again, more digital applications. We are logging into digital applications without knowing the repercussions of giving our data there. We are continuously putting in information and going to seek healthcare consultations on our phones, right? It is positive and it's also negative. We are seeing that more people can now, yes, consult doctors online, but on the other hand, you might consult a quack doctor. They might give you the wrong prescriptions. They might give you wrong advice. So it is always important to have a mix of both, Patricia. I believe that having a mix of both digital health technologies as well as the healthcare systems that we're using right now will be important for us to just have better services. Yeah.
understand from your perspective representing teachers but as well as students that are under your care.
Thank you, Patricia. For me, just as Cindy has said, the coin has two sides, and personally I like talking on behalf of the young ones. Many a times their data is misused in schools. We have the UPI number, we have the NEMIS number. Everybody is collecting that, but the question is, the bigger community, that is their parents. Some of them are so ignorant that they just give these numbers without asking what they are going to be used for. I think it's important, especially when it comes to the school-going children. Sensitization is done to the school administration. And for those of them who are on medication, it's even worse, because you find some of these children, they go to the CCs. The school is not aware, the parent is aware. Like now, most of them will be going to Form 1. The parents have not come clearly about their HIV status. So at some point, this kid will need to go for their medication, because the school term is 3 months. And most of them, because of adherence, they go for their medication monthly. You find sometimes this number is given to more than one teacher, and it can be an issue. Some of them are curious because they really like to know, what is this number being used for? I remember when we were doing the data, the national data verification, as a communities or people living with HIV, we were very jittery about the whole process. Not that we didn't know, but our why was, where is our data going? And then we had so many versions. And I remember in Machakos, at some point, there's somebody who told us that our data is not stored in Kenya. And as people living with HIV, we were like, how? This made us become scared, because you don't know what that data is being used for. So what we are simply saying, the systems that are there, yes, they should continue being there as we embrace the digital and technology platforms. Especially in the education sector, there is still a lot of ignorance as far as technology is concerned. Most of the teachers, I can tell you for free, have not embraced technology. I know you normally hear this thing called the T-pad. If you don't fill in the T-pad, you're not getting your next pay. Most teachers in the rural areas, believe me, miss their pay. Why? They cannot go through their T-pad. So what are we saying? For the sake of even these learners and for the health system and the health provision, as teachers, we need to be sensitized. We should have a comprehensive interaction with the Data Control Act and know what really it is. That way, we will be able to take care of our data in school, and we just don't give it out. Being teachers does not mean we know it all. There are some things we are really ignorant about. I may be knowing it, but in Kenya we have about, the task force is about 700,000 plus, and we are still employing new teachers. So I think for us, we really need to be sensitized on these issues, digital and technology as far as health is concerned. And for the communities, yes, we are still not very comfortable because we don't know where our data is. Thank you, and over to you, Patricia.
Thank you so much. So for Peter, we know for a fact that men have a problem in terms of seeking care. What potentials and opportunities do you see for expanding digital health solutions in this community?
Thank you, Patricia. I'll concur with my colleagues, and I'll mention a few things about men also. Before this conversation of digital health came into public like it is today, we used phones. The digital communication was there, and mostly probably men were using it more frequently than the women because of the stigma associated with men and the fear. Like a good example that most men, if you get men in facilities, at least they have the contact numbers, phone numbers of the clinicians or the doctors. Why do they have this one? Because they rarely go to the facilities, but they use the phones to call. You can even get sick during weekend. But if you call your doctor or your clinician using that's the digital aspect we are talking about, you'll converse with him, and the moment he'll ask you that how are you feeling, then you state how you are feeling, because you normally don't go to the pharmacist and the chemist and we talk about our status. So the doctor will ask you, which medication are you on? Then he'll tell you that buy this sort of drug. That will not interact with your ARVs. So the digital health started sometimes before even now the conversation is all about. Another thing about the other side of the coin, which my colleagues have also talked about, when the issue of APNS came, it was something which touched on issues of stigma. It touched on issues of confidentiality, and we didn't take it lightly when it was being introduced, because we didn't understand it when we were being told. We were not part of how when it was being started, because unless and until the programmers stop seeing us as targets and not recipients of care, because we were being used as targets to reach somebody's target. That's why even when the digital health, I hope it will not be used for reaching the target, but helping us as recipients of care to get quality health care, and again to keep the confidentiality about our data. Men in particular, when it comes to accessing medication, it's not easy. So with digital health, I hope there should be an aspect how it also needs to target men directly when it comes to how somebody can come up with a better target, not a general one, but a better way out we can reach out on men with using the digital health platform, so that at least we be at par with our women. So in all, the digital health is also helping in some sort of ways, and if it is improved, the way my colleague has said about the issue of data protection. Yesterday I asked about if you have a PIN, how frequent do you change the PIN of that platform? Because people come and go. If I go and leave, do you change the platform? Do you change the PIN? Because somebody else will be now acting on that, handling the data. So it's something still complex, and there are some also gray areas, the questions Dr. Stiney was asking himself also. There's some tough questions, and I think it's part of the team that came who is supporting the digital net. But there are some gray areas also asking questions. So if he's the one part of this team and is also asking some questions, who will answer those questions? Thank you.
Thank you so much, Peter. Certainly, you are getting it from what Peter is saying. I know that quite a number of people in the room are wondering what Peter is talking about, APNS. Do you understand what that is? Do I need to clarify it? So APNS stands for Assisted Partner Notification, that when you go for testing, that the clinicians are asking you whether they could be able to assist you to disclose your status to your partner. But they've used technology, they've used phones, because when you go there, you are coerced sometimes to give you phone numbers. I heard yesterday about Article 31, about, was it about privacy? Lawyers, what is it about? Right to privacy. Yeah, but you know not all of us are aware of that. So when we go to the facility at times when you are asked about the phone numbers of your partners, we give them without even seeking their consent. And so using that technology, at times the clinicians use that to call your partner without your knowledge. So that is what Peter was talking about, and that is what has created the fear where we sit, that the technology is going to be used to stigmatize us, to violate our rights, and that our data will be all over. Like recently we were in Homa Bay, the people who were in Homa Bay, and some of us were so eager to go to the platform when we were launching the RRI for children. Just a colleague told me the other day that she did not go on that platform. The reason being that she's a key population, and her customers are some of the clinicians. So this digital platform, you know, the clinicians will have access to it, and we are concerned, some of us are concerned about our status being out there, that they'll access it. So we're just wondering, how will that be protected? Daktari, when you get the opportunity next time, maybe you'll be able to explain that to us. So Cindy, I want to give this one to you. How can digital and data be leveraged to promote preventive healthcare and wellness in our community? Like now we are pushing for more of a PrEP, yeah, and also the new prevention modalities about the ring and other modalities. How will that be able to? How do you see that?
So in regards to especially HIV prevention, I think right now I am seeing a lot of products, a lot of very nice products, a lot of prevention products, especially for young women, for children specifically. And I think it's a move to the right direction. We are seeing that there's more women-centered prevention products being produced. We are seeing that, I think at one time I saw that they are looking at a patch for children to be placed at the back of their somewhere here. Yes. For it to prevent a child, you put it on for 1 hour and it prevents it prevents HIV for the whole day. Yes, so you have a patch, you know the way there's like that patch for smoking, that one, the nicotine patch, you put it at the back of the child and then it prevents HIV for that day. It's still in trial, but those are very, very beautiful ways. I don't know how many of you have children, but if you have a child and they are exposed to HIV and you want to administer medicine, first of all, the previous ones were not even dissolvable in water. They were very bitter for children. So any improvement that will make a child not have to go through that is accepted. Any type of ensuring that people can access treatment in an easier way, that is more cost-friendly, that is also very accessible to them, will be a step forward. Looking at women specifically, we are seeing that, for me, long-term options would work very well. Getting an injection once, going for an injection once a month, and then being told that you are prevented for that whole month is a very good step, because you don't have then to worry about that one boyfriend will tell you they don't want to use a condom. You don't have to worry about that that sexual partner who will beat the hell out of you because you said they have to go and get tested. You know, all these things will be improved, but also we have to look at the privacy of this individual, the usability of the product that we are bringing, and also the ease of use for the end user. Yeah.
Thank you, Cindy. Thank you, Cindy. Odemo, what potential opportunities do you see for expanding digital health and solutions in your community?
Thank you. Thank you for that question. The opportunities which are there, which is happening even now, we also have, we can have adherence, the counseling adherence at the support group. Nowadays, it's rare we have very few support groups, people meeting physically. But we have support groups, we have apps where, our WhatsApp groups, where we do the support groups. And that's part of the digital, those are the opportunities which are there. We also do adherence. You can reach out to anybody, somebody who is far away from you, and you can know how he's going or how she's going. So those are the opportunities which we are coming up with, which the digital health is also helping us to achieve. Again, we also deal with issues of confidentiality. It addresses issues of stigma also with through those digital apps. Like now, NEFAC, we are rolling out stigma index, and most of it will be digitally used, so that you won't get somebody's details openly. So there are a lot of opportunities with digital health if it is handled the way it's supposed to be. And I know moving forward, it will be improved, and the issues we have with it will be addressed. We've been talking about community pharmacies, things like that. These are some of the things which the digital health the aspects of digital health will be addressing, and issues of the KAGs, CAGs, community ART groups. So those are some of the things we need also to encompass, to put together, and how we can do it better through the digital health. Thank you.
Cindy, you want to add something on that?
Yes, I also wanted to add the fact that there's also an opportunity to improve our access to our own data as well. As persons who are living with HIV, we have a lot of routine monitoring, and we barely get our results back. You go to a facility and they just tell you are doing well, you're doing fine, blah, blah, blah. But I think it's also a very big opportunity for us to access our own healthcare data, that you can be able to sit at the palm of your house and see that my last viral load was 70, my last viral load then is 50, and you can see the improvements on your own end. So I think that's a very big opportunity. And then I'm also looking at online consultations. The fact that I can sit at the palm of my house and talk to a doctor, a qualified doctor, through maybe a Ministry of Health app, and they can tell me that this is the right thing for you to access, and you can access it at this and this facility. It will be a very big step. It will decongest our health facilities as well, just enabling us to have like express systems of accessing healthcare. One last thing I am also looking for, we can get early detection to different services, because we're seeing that more and more young people, more and more older people who are living with HIV are also getting to the NCD's side of health. We are seeing that with better healthcare also comes with weight gain. We are seeing all that. Our blood sugar levels, our glucose levels are also getting high. This will also be an opportunity to just ensure that if you can be routinely monitored but from at home, that is better, and you can get your services at ease.
So, what are the opportunities that you see for teachers and also for students on the digital health platforms?
Thank you so much, Patricia. For me, in the teaching profession, I see a platform where we can talk freely about our HIV status. Before, as a teacher, you could not talk about HIV status. The next thing, the parents would withdraw their children from school. I think there's so much that has happened. HIV issues being talked in public. We have the different platforms. NEFAC has done us so proud because we have that bulletin that circulates. So it reaches even to the parents. Ministry of Health, NAC, they have all these advertisements. And you see they're looking at different levels. So even the learners are eager to know. And especially those who are born with HIV. Before they could not talk about it. As a teacher, having gone public, I'm proud that my learners are able to identify with me. So whenever they even see me on television, they are like, our teacher was there, and they feel so proud. But before you would be seen, the next thing, I remember there was a school I was in. Children had to be withdrawn from my class because I talked about my HIV status. And in that class, I was having about 12 children who were HIV positive, and they were identifying with me. So the parents of these children were like, if our teacher is going, wherever she's going, we are taking the children there. So wherever I transferred, those children followed me. Then the parents were like, why? They were criminalizing HIV. But with the ministry, we had to embrace it at the national level. The Kenya Network of HIV Positive Teachers, we are in all the 47 counties. And TSC is one employer that has given us the opportunity. Whether you are HIV positive, you still get the job. Other employers don't, and they really support us. And it has taken a lot of push and pull to tell them we are here, we are no lesser teachers, and as you take care of us, the opportunities should also go to our learners. For a very long time, we've not had the school health program, but I'm glad I was able to push it, and it's back. Even in the next grant, we have so many opportunities where these learners, not only those living with HIV, are able to talk freely. We have the buddy system that we have introduced. We started it on a digital platform in our own small way with some schools. But in most of the secondary schools, the buddy system is working very well. We have the psycho-support groups at school levels. We have the health clubs. And we even do benchmarking from those schools that are doing very well. So I think the digital platform for us, it's an opportunity that we've gotten to explore and get to give these learners the best. HIV is not a death ticket, and this is what we keep telling them. But you see, for the learners, they really want to see the reality. Teacher, you have lived 22 years. Can I be able to live the same? You have to give them that assurance. And how are you giving them assurance? Give them those pamphlets. For the young ones, they love reading. We have the digital platforms. Liverpool has the 511. There's a number. They can talk to the clinician on one-on-one. There are those things that the children cannot share with their parents. But as a teacher, they can share with me. And we are talking of the privacy. They have a reason why they cannot talk to their parents, and they talk to me as a teacher. After getting to me, do I share it with the parent? No. I have to keep that confidence because they have confidence in me, so I have to do that. So the opportunities are very many, and we are looking forward to even lower the triple threat with the innovations that are coming up. Thank you.
I've been told my time is out, but I think you can allow me to give my panel to give us a parting shot each. So we'll start with Cindy.
Okay. So for me, I think my parting shots would ideally go to the government. I think when it comes to digital health, it is a very big opportunity for the government to have open and honest conversations with its citizens, and just telling them this is how we are using your data, this is how your data is protected, this is how everything is going to work. Because the lack of transparency between us as the end users and them as the people who are creating the platform is what is creating this back and forth with us not trusting where our information is going. So I think opening up channels for open and honest conversations about digital health tools that the government wants to put in place will be very important to just ensure that we are comfortable with using those digital platforms.
Thank you. Yesterday from morning to evening, we talked a lot about access. What are we accessing? Did we consider the supply chain when we're talking about the digital health access? Did you also consider availability of commodities and quality of services? I'm saying this because some few months ago, I missed my medication for a whole week. The medication was not Bagati, but it was at Kemsa. What's the distance between Bagati and Kemsa? The bureaucracy. Is the digital health going to address the bureaucracy, or the human beings are still there who will be handling all these digital gadgets? It happens. And I hope with digital health, let it be in such a way that the bureaucracy which is there, that the drug is in Kemsa, but it's not at Bagati. For a whole week. I got it on the second week. That is in Nairobi. What about far-flung areas? What will happen? How long will it take? Thank you.
For me, I think my parting shot, as a government employee and somebody who is trusted with the lives of children, I think at the policy level, we should be part of some of the policies that are being put in place for these young people. They cannot be on that table, but some of us can be there to be given an opportunity to speak for them, because many a times we decide for them. We really don't care what they feel and what they want. So an opportunity for us as teachers to share what these children are going through, I think for us it would be handy. HIV comes with so many things like mental health. We are having so many of our learners committing suicide. Why? Because they want somebody to listen to them. Nobody is listening to them. The only person who listens to them is that teacher. And this teacher is supposed to be in class full time. At the policy making level, I'm not involved, yet I'm the one working with them. So to the government, involve us in policy decision makings for these learners. Thank you.
Thank you so much. Our session is over.
Thank you. Let's put our hands together for them. Thank you. Just before you exit the stage, we'll take 3 questions. First, 3 hands up. Going 1. 1. Okay, 3. And then you'll respond, then we'll take the online ones. We'll start with ladies first, yeah?
Thank you so much to our panelists. Mine is more of a comment and a question. I know we keep talking about data privacy. We also talk about inclusive health. Yet the people who are designing these systems and these platforms are not part of this conversation. When we talk about technical expertise and whatnot, just talking about privacy, encryption on its own is not enough. When we have the tech guys being present here, we'll be able to answer certain questions that would be really pertinent to some of these conversations. We talk about two-factor authentication to access some of these systems, but there's a layer to privacy that goes beyond just the simple structures that we have.
Thank you. Sorry. Martha?
My question is not only about digital health, but I recently learned that we have been conducting blood drives in schools. I didn't know it was happening for a very long time, but I discovered that. And through that, as you donate blood, or as children donate blood, there are also tests that are done. And some of these tests, or actually these tests, reveal health status. So would the use of digital health to have, first of all, informed consent for parents, because the parent is the guardian of the children, or is the guardian of the child. First of all, will it be better to have digital health being used to gain consent for parents to have their children, first of all, even donate blood? Because there was a case of a child whose blood was donated, and the school said that they shared a WhatsApp message to the parents, and they didn't wait for a response. That's the use of a digital health platform to seek consent. However, they still proceeded with the blood donation or collecting blood from this child. And then there are also cases of probably a child having donated, having received blood that was donated. So would are digital health platforms adequate, in your opinion, especially Anne, dealing with children? Are these platforms convenient, first of all, to gain consent and informed consent for that, in that case? And then there's the whole discussion on interoperability. Information can be accessed from any corner. And maybe this would also go to Dr. Sitiene or anyone who has adequate information. Sylvia, the superhighway, is this information shared even to schools? So that they know that probably Martha received blood the other day, so I'm not in a position to even donate blood in the first place, or something like that. So do you think digital health platforms would be adequate in case of minors and in case of cases whereby tests are done without proper authorization or consent?
Thank you, Martha. Last one, please make it brief.
Thank you very much. Considering what Peter said in his closing remark, I was hoping that there should be some mention about differentiated drug delivery using digital platform, like in South Africa, where you have the ATM and you go to the ATM and get your drugs without any going through that long process of queuing. Do you think that one is possible, using a digital platform for differentiated service delivery?
Thank you, Patricia. Your team, you have 2 minutes to respond, then we'll take the online one.
I think I'm going to respond to my student. She was my student, and I feel so good seeing her here. She noticed me after very many years. Thank you so much, Martha. Now, I think the digital platform would be a very good platform for the consent, because in most cases, the blood donating drive, sometimes they come to school, and all the children, like secondary schools, they're really excited, they want to donate blood. And here is where you find some of them are living with conditions and they don't know, because their parents have told them, please don't say that you're living with this condition. Take your medicine but keep quiet. So I think the digital platform would be a good platform for the consent purposes. And again, it would be a good platform to inform the rest of the society the importance of that, and having the test, different tests, before that blood is donated.
Thank you, Peter. But I think what we are asking is a bit beyond me. because I'm also asking that. Because we are still struggling with having a community pharmacy. But now we've gone far to the ATM. So let us call first and let's see how the digital guys can come in handy when it's come to drug dispensation digitally. Thank you.
For me, I think it's very possible. One of the things I have seen NASCOP actually do is they have piloted, they continuously provide, self-test kits through MyDawa. They also provide PrEP through MyDawa, right? So if that can be done, I believe that people can also access their medication via any platform that the government sees fit for us to access.
So thank you very much. We have, Yeah, we have 3 questions online. So the first one is, do you think it's time CC services are integrated with other services instead of having clinics specifically for HIV? Second question, some 2 years ago there was a case where students reporting to a certain high school were forced to undergo compulsory pregnancy and HIV testing. Does this promote stigma and further criminalization? Communities work together to advocate for better access to digital health resources. Honestly, I'd expected this session to attract more questions. We have all the 47 counties represented, and from yesterday's roll call, the majority were from the community, right? The people who receive the care or give the care to. So don't feel pressured. Just go to yourminty.com and post more questions. We'll get another opportunity to ask, because I think this is an important one. All that we are discussing is for the benefit of this community. Sinikweli, why are we here? Why do we have this conference? To tell government what to do to improve the lives of our people. Sinikweli, yes. So I'll allow the panel to take the 3 questions, then we'll give them a round of applause. Thereafter, more announcements shall follow. Thank you.
I'll tackle the first one about integration. It's very important, especially when we have integration services, TB integrated with HIV. Why am I saying so? Sometimes you can, if you're HIV positive, you can suffer TB, but to diagnose it, nowadays I think it's easier. To diagnose it, it becomes difficult. I went through such, I had TB, but it could not be diagnosed through X-ray, and X-ray was pneumonia. So I was put on pneumonia medication for quite some time. By the time it was being discovered, it was TB, it was discovered at the CCC, not at the TB clinic. So if at all it was integrated, I would have been helped much earlier. Again, when I was put on medication, I started going on the TB drugs was getting with my eyes. So it was detected at the CCC, not at the TB clinic. Then again, I was misdiagnosed with TB, and I was put on injection during the time where relapse was being injected, and I was admitted at Bagati. By the time it was being discovered it was not TB, I had gone through 33 injections. So integration can alleviate some of these things which I'm talking about. Thank you.
I'll take the second question. Is it compulsory to do the test? Now, for HIV, it's not compulsory. But after this long holiday, believe me, schools have to take the pregnancy tests. Even when we were school going, even at college level, after the long holidays, even at TTC, it is done. The pregnancy tests have to be done. Because remember, these kids are going for a very long holiday. We already have some, like the junior secondary. We have a big problem there. So we need your support, parents. So now when it's put that it's HIV, specifically HIV, that again is stigmatizing. We used to have very many protocols at the Ministry of Education, but thanks to the late Professor Magoha, it demystified most of them. And especially when it comes to medication and health issues. Most schools were throwing drugs when children are being admitted. Now very few schools are doing that. In fact, any child having their drugs, they go with them. In most of the secondary schools, we have introduced a buddy system for them, where all the children taking different medication have a place where they are the ones who operate themselves. And there is a child on duty every day to remind the others, it's time for us to take medication. So there, you will not find stigma, because you have somebody who is a sickle cell anemia case, an asthma case, a diabetic case, HIV, so they are all there together. HIV tests, most of the schools, like when they are going for Form 1, there are those schools which still demand, but it is not right. Yes, it's not right. Yeah. But a medical report, a comprehensive medical report should be given. But most parents go to their buddies to get the medical report. So the teachers detect later on that some of these children are living with HIV. But the question is, are they helping the children? That is a question to you. Thank you.
Taking the last question on how local communities can work together. First things first, we really need a lot of emphasis from the government, especially to come and give us open channels for us to understand how exactly our data is going to be utilized, how are these platforms being created, how is the security and privacy being maintained, right? Because once we understand, then we are able to build consensus on whether we are pro-digital or we are against those digital systems, right? Because we cannot start building consensus from a point of we don't know. I remember one of the things that when they wanted to introduce the NUPI system, and the guy that came to like explain the NUPI system kept saying, that's above my pay grade, that's above my pay grade, I don't know about that, but I can show you how the system will work, right? So we had a lot of questions, but no one was answering. And because we can't get actual answers, people said if you can't give us the answers to that, then we don't want it, right? And it faced a lot of opposition right after that, with people saying that it will not serve their needs per se. However, if someone would have come in who could say how the system works, I don't think there will be any opposition from communities accessing those platforms. It will be easier to convince an informed crowd about why they need this than to convince an uninformed crowd that is already very on the opposition side with the government.
Thank you very much. Please let's give them another round of applause as they exit. I would request Anne to remain behind as the rest of the team take their seats. Thank you very much, Patricia. That was a wonderful session. You know, sorry, Anne, not to put you on the spot, please. You know, we are all here because of our teachers, and we must celebrate them. So I would request the cameraman, please, can you take Martha and her teacher a photo, please, kindly. Yeah, na msisemu mwalimu wa Martha hapa ni wapi? Just kidding, okay? Yeah, we are very proud of how far Martha has come. Cameraman, please. Thank you very much. Asante sana. And you see, you did a very wonderful job. Now she's here. You know, you know, when I was coming here, driving carefully, watching my fuel gauge, there was a conversation in one of the radio stations about teachers, yeah? That sisi tuko huko, unakuja Nairobi na kulima mawe, lakini when you go back home, you meet your teacher who taught you 30 years ago, still the same, huh? They never change. But say tuko huko tunakaa wazee, unashangaa huko ni wapi? So look at that. Look at that. 34 years. Tumpigie makofi tafadhali. Thanks for the amazing work you're doing. 9 years to go. We are proud of you. Thank you. And we'll make sure that Martha, you better prepare a gift for your teacher, because I won't forget this. Thank you very much. I know that you want to comment briefly, but as you comment, we are going to take a break. I want to request humbly my panelists. I know we have a panel that was supposed to start 15 minutes ago. We are running a little late, but we're going to recover that time and know how. So I'll request that we take 10 minutes, 10 keeper, just so that people can grab a cup of tea, and please bring them in because the weather is not very friendly today. It's been raining. Karibu Nairobi, for those who are coming from Kisumu. I know you might need another jacket on air. Yeah, so thank you very much. I'll give Daktari a minute to comment as we step out to take a cup of tea. And I want us to do it this way. We start with the last row so that we don't congest the area. Please take that time also to relieve yourself if you have to. I saw your hand up. Go first, then Daktari. Thank you.
For me, it's just a comment. So I'd like to thank Teacher Ann for the good work that you're doing. We have noted, according to the data that we're seeing, there's a lot of teenage pregnancy that is happening, leading with Meru at 26%. And this is something that I think a great intervention needs to be done, especially with the digital health platforms, because that is where most of these children are. So as talking to the people in the room who are in digital health and the government, we need to look for interventions that can help our teenage girls. Thank you.
Thank you very much. Thank you very much. Daktari, and then please, there's some water bottles just behind here. If you need one, kindly pick during this break. Daktari, 1 minute, please.
Thank you. I'm not going to take time, but the more I listen in to these conversations, the more I recognize that there is paucity of knowledge amongst us and maybe even beyond this space. And maybe this is an opportunity for the teams that have organized this conference to ask themselves, how do we pass knowledge out there, particularly on what the government is doing in this space of digitization, and also focusing on how the data will be taken care of. Now, I know some of you may know this. If you, because internet here is free, if you type in your smartphone health.go.ke, you will find that the government has moved to the next step of providing services there. And I thought about this because I think the issue of blood came up. One of the services that you will get in that space is for you to be a blood donor, so that anybody can book when you want to if you want to be a blood donor, you put all your details there, including even where you'll go for blood donation. In other words, the government is being very futuristic to an extent that it is our hope that there will be a portal, and if you saw my presentation, there was a portal where Wanjiku can be able to log in, get their data uploaded by themselves, for example, using devices, your blood pressure, your blood sugars, and that forms part of your report. In addition to that, that portal will enable you as the consumer to be able to book appointments, to see who is the nearest surgeon or obstetrician. I know some of us may be interested in that field, or whichever. And you can book your appointment online. That is the future that the government is taking. And if you go to that portal, you will see that the steps are being taken towards that, so that people can be comfortable to access their own data, to be able to book appointments and to access care in whatever facility they need, following the primary care networks that have now been officially launched. Thank you.
Thank you, Daktari. The government is moving, we are moving towards the right direction. So about now, we are going to take a break, 10 minutes break for tea. I know there are people with appetite, no food. there are people with food without appetite. We are blessed to have both. So please, let's go out, have our tea for 10 minutes. You can bring your cup of coffee or tea to the room. If you need water, right behind you, there are bottles of water. Please pick one. You need to remain hydrated, as doctors will tell us. 10 minutes starts 2 minutes ago. Thank you. Oh, and if you've not registered, please make sure you register. The registration desk is on my right, just next to the window. Thank you.
Sanaji, kindly come to the front.
Please let's take our seats. If you are outside, the next session is starting in a few minutes. The next session is starting in a few minutes. Hello. You can bring your tea in. Okay, so please let's be ready for the next session, and we are interrupting the program just for 5 minutes for the sake of our colleagues who had requested to leave a little earlier. So there is a launch ceremony for one of our beautiful publications. So I would request the following people to join me on stage as we launch this particular publication. Dr. We are requesting the pleasure to have you join us for the launch. Kindly. Kennedy, I'm directly looking at you because I want to request you to join us also for the launch. May I request you the pleasure of you joining? With May I request your presence, please, to join us for the launch, kindly. Florence, I'm looking straight at you. Kindly join us for the... Where's Patricia? Patricia, your presence is requested here. Patricia? we'll launch it, yeah, if you could just, yeah, on the stage. Patricia, please come and balance this equation, otherwise I'll be in trouble. Oh, she's outside. May I request your presence, please, kindly. Join us for the launch. May I request your presence, please, to represent the young people. Thank you. So we are launching a publication, and to speak to us about this, I'll request Synergy. Yeah, I didn't want to get it wrong. Just in 1 minute to tell us what this publication is about, and then we'll proceed with the launch ceremony. Karibu sana Synergy.
Thank you very much. Good morning, good mid-morning, distinguished delegates. What is about to happen is that we're going to launch a document that speaks in brief about digital health technologies and data in Kenya. What is contained in the document are a set of best practices on what should inform an effective digital health ecosystem. The document commences with a number of principles. We have data integrity, we have value proposition, we have technology neutrality, and the integrity of data. So the document speaks in part on what the government should do in terms of regulations and guidelines that are going to operationalize the Act. It talks about, it addresses both the demand side of digital health. It also talks about the supply side needs, and it also talks about cross-cutting issues. So within the document, you will find aspects such as dispute resolution, which is not covered under the Act. This provides an avenue for consumers of digital health to access certain redress measures, both from the platforms that provide these services and probably through regulations that will then inform how digital health is going to be operationalized. We also have aspects such as communication interfaces and use of alternative technologies to ensure that all cadres of the population are covered within these services. We also have the aspect of we have public information and education and creating awareness just to ensure that the outreach also transcends all populations. It addresses the issue of digital divide, digital literacy, and the need to drive up the digital skills. So in a nutshell, the guide provides certain best practices, both in terms of technologies, softwares, systems, communication interfaces, aspects such as communication and network connectivities, which all address the wholesome digital ecosystem. Thank you.
Thank you very much, Synergy, for that brief. Please make sure you have copies. We need one more copy. And ladies and gentlemen, we are well energized. Martha, can I get one more copy? And I know we have enough copies. Right, it's okay. We have enough copies for everybody. So right about now, we are proceeding to launch this beautiful publication. Synergy, okay, you can join. Just one more copy. Oh, you have the copy. Oh, he has the copy in his head. So, ladies and gentlemen, we are launching the publication written legislative guide on digital health technologies and data in Kenya. May we all be upstanding, because in 3, because in 3, 2, and 1. Thank you. Thank you. Thank you. Thank you. Thank you. Please, let's continue clapping. Thank you. Thank you. Thank you. Thank you. Thank you. Beautiful. Beautiful. Please make sure you get a copy of this book, of this guide. Thank you, thank you, thank you, thank you. Thank you very much. Thank you. Thank you. Please make sure that you get a copy of this guide, because already we have 4 Bibles. So by the powers vested in me, I declare this as the 5th Bible. Make sure you read it, okay? So the first Bible is the Bible written, that the Bible we all know. Then the Constitution of Kenya, the Data Protection Act, the 3rd one, the Digital Health Act, the 4th one, and then the last one is now this particular publication. This is the order of the Mass. I'm guided, thank you. So we are going to the next session. May I request the presence of Trevor, please? Trevor? Just 1 minute, please. Come. Yeah, so the next session, requires me to shed off my other self. Can I get emails? Email. There's a email. Just recently. Yes. Just double click it to load up. Just double click. Thank you, Trevor. Thank you. Yes, so now, ladies and gentlemen, shedding off the other life and stepping into a new role as the moderator for this session on resourcing for digital health implementation, opportunities and gaps. Every time I talk about resourcing, my work largely is around public finance management, governance, and policy and advocacy. And every time I get an opportunity to talk about things that are so dear to me, like the public finance, there has to be a preceding bad thing that is happening in the country around the PFM landscape. The last time, I think, currently we know the story about the fuel prices going up by 300 shillings. We all know about that, right? We know about the government saying that funding free primary education is becoming an uphill task. We saw that. We know about the Eurobond maturing in 2024 next year around June. $2 billion US dollars with the current dollar rate, $1. Are we going to survive as a country? Would we have money to finance our digital health programs? That is the biggest question. The tax expenditure report is out. For those who follow this conversation, please look at the report. How much revenue have we forgone as a country? And what does that translate to service delivery? KRA has written to AMBMB in Ireland to request for the records of all hosts in Kenya from January of 2021 to December of 2022. mmefikiwa. We are told, yes, that's what we want to understand. Our loan repayment to China has risen by 36%. A report by the Treasury, which means we are going to pay 40 billion on top of what we are supposed to pay to China. Then another interesting one is that the CS Lands has said that she's going to review the land rates by almost 100%. And then lastly, we are here to talk about financing for digital health. So with that background, driving while watching your fuel gauge, moja ikianguka unasikia sasa umeisha. Si ni kweli? Ukienda kwa pump, you're wondering what's happening. But at the end of the day, we must get ourselves out of this situation that we found ourselves in. So to help us put into perspectives the discussion around resourcing for digital health, because all the beautiful things that we've said since yesterday would only happen, even that superhighway, the digital superhighway we were shown yesterday by Sylvia and Tim, would only become a reality if we have resources to finance it. True or false? Cynically. Yeah? The CHPs, the county health promoters, would only be effective if they can go to their ATM, not like what Peter, was it Peter or who? No. If they can go to their ATM and get some money. I think it was another conversation where you go to withdraw your salary and you realize you do not have a salary. What you have is a pay slip. You don't have many money. So to help us put all this into perspective, whether Kenya is prioritizing in terms of resource allocation to health and specifically to digital health, please help me welcome on stage my first panelist. My first panelist is Kennedy Okongo. Kennedy is the Director, East Africa Medical Credit Fund under the Farm Access. Is a career banker with over 15 years banking experience. Current duties include participation in the underwriting processes for all plans in in East Africa under the Medical Credit Fund, supervision, training, guidance of business analysts and business technical partners. Main link person with the partner, supervision of Medical Credit Fund portfolio with the partner institutions, relationship management of the large private healthcare providers in East Africa in liaison with the respective county teams. Prior to this role, he worked in several banks in different capacities, from the level of business relationship officer to branch manager in KRET Bank, now the Sidian, Equity Bank, United Bank of Africa, Chase, now SBM Bank, and Group BMCE Bank. Please put your hands together for Kennedy as he comes on stage. Thank you, Kennedy. We are pleased to have you. My second panelist is Dr. James Sierra, country lead to East Africa, a colleague in the space and a great friend of mine. We have done some great work with Twaiza East Africa. Just to highlight a few, during the discussion around the Finance Bill 2023 now an act, you might have heard along the corridors that 93% of Kenyans rejected the bill. Did you hear about that? That was a survey that was conducted by Toeza East Africa and the Center for Fiscal Affairs, which I'm proud to be the lead. So Dr. James Mugwa Siara is a statistician and works as a senior data analyst and country lead Kenya at Toeza East Africa. He has a PhD in statistics science. James has published over 20 peer-reviewed papers in several internationally recognized journals. Before joining Toeza, James worked with 2 other international NGOs, supporting them in data collection, management, and analysis. He has also taught at the Kenya Methodist University for 4 years. In his short career, James has been involved in many impact evaluation studies in different areas, which include education, health, nutrition, agriculture, and governance. Please, let's put our hands together for Dr. James Siara. Daktari, karibu sana. We are pleased to have you. My third panelist is John Kinovia, Senior Program Officer at the International Budget Partnerships. Wangapi wamesikia hii mambo ya IBP? They have been conducting so many budget transparency surveys in the country. We might have seen 1 or 2 of their reports. So John is a Senior Program Officer at the International Budget Partnership, and he has worked in the public finance space for over 10 years. He leads IBP Kenya's programmatic work that is implemented at the county and national level. He is part of the team that works to promote budget transparency, inclusion, equity, and how the government raises and spends public resources in Kenya. He has extremely researched Kenya public finance management system to generate evidence that IBP uses to provide technical support to CSOs and government agencies. John's research focuses on equitable revenue sharing mechanisms, equity in government expenditure, social protection, public debt, government cash flows, budget credibility, public participation in budget, health financing, public debt, subnational budget transparency, among other areas. His role also includes supporting capacity building and development of guides and tools that IBP uses to improve CSO's capacity in engagement with national and subnational government budgets. John holds a Bachelor of Science in degree in Physics from JKUAT and an MBA in Strategic Management from the Kenya Methodist University and a Professional Award Certificate on Decentralization and Local Governance from SOAS University of London. Before joining IBP, John worked with Toeza East Africa. Wow, I didn't know that. As an associate analyst, where he helped to build the Kenya Budget Explorer, a centralized budget portal to improve citizens' access to budget information. He is a cyclist, a happy bee farmer, and a part-time historian. We're gonna get some honey today. Thank you. Please, let's put our hands together for John Kinovia as he comes on stage. Thank you. Thank you. As we begin this conversation, first is to apologize profusely that my panel is not balanced. I needed to say that because otherwise I'll be in trouble. You know, I'm a gender champion and I'm always very sensitive, but for this, please just turn a blind eye for once, okay? I know ladies are saying no, we're not going to let this go, but please. So we'll start with a brief introduction, and we'll start with Mr. Kennedy Okongo, just to tell us about what is this medical credit fund as you introduce also your organization, just in 2 minutes, and we'll take 2 minutes each to introduce ourselves. I might have not mentioned some of the things that you'd wish the audience to also know. Thank you.
Thank you so much. I believe what I need the audience to know about me, you've said it. Beyond that is considering that we are talking about data privacy, things that we can meet behind the blue tent to discuss. I represent Medical Credit Fund, which is an organization that deals with providing debt capital in the health space. By debt capital, in a layman's language, I mean loans to healthcare providers, just to enable them be able to move from point A to point B, be able to offer the services that they are needed so much in this current world. Thank you.
Thank you so much, Kennedy. You know, from where I come, if we talk about debt capital, it means something else, but I know we've understood what it means, right? Debt capital for us, it means something else. Yeah, you take some few millions, put very beautiful home for the butterflies. Thank you, Dr. James.
Yes, thank you for the introduction that you have just made a few minutes ago. James, I work for Toweza East Africa. Main goal is to link policymakers with citizens. So basically what we do is to go out, collect information on various topics, on issues that are affecting their livelihood, package this together, and then share this with the government. And we also provide platform to have citizens on one side and policymakers on the other side, and they can be able to discuss some of the issues that are affecting them. One, they be able to put them into, make them accountable. And on the other side, citizens are kind of forced in one or another to understand some of things that are happening. And from there, we're able to raise the awareness. And when this happens, we have a good interaction between service provider and those who receive their services. Beyond that, we also work in several coalitions like Okoa Uchumi. We have had the issue, all the issues that were dealt with before. And I'm happy because it's part and parcel of some of the issues that we are looking forward to hear citizens, what they are saying in terms like the new NHIF thing that is about to be rolled out. There are a few things that have been done. So I'd like to hear what's the citizen opinion with regard to the implementation of what has been proposed. Thank you.
Thank you very much, Dr. John.
Thanks, and I apologize. I did not know that he was going to read the whole profile. I thought it was for his notes, but it's okay. So that says a lot about who I am. I work for the International Budget Partnership Kenya. For us as an organization, we come from a very basic premise where we believe that anyone can engage with government budgets. It doesn't matter whether you are educated or not, doesn't matter whether you are a man or a woman, anyone has needs and basic needs that are met through government service delivery, and that means that all of us can actually engage with the decisions that are related to how those services are funded. And so for all the research that we do, any technical assistance that we do, a lot of it will always be to make sure that that space where we make decisions about government resources, which are our resources, that is done in an open manner, it's done inclusively, government is accountable, and we are now running a decentralized system of governance that space is also taking care of issues of marginalization. So thank you for having us.
Thank you very much. Tuwapigie makofi tafadhali. So, just to maybe start us off, I would want to know now, from IBP standpoint, I mean, what does digital health mean to you in terms of advancing conversation around UHC? And do you see opportunities for that can be harnessed to make health more accessible, affordable,